Yeah, there we go. We've got our panel together. Welcome back, everybody. So the first question is for Dr. Vez or for anyone, what type of pillow would you recommend for somebody with Chiari?
So it's not really so much the exact type of pillow, and it really depends on the curvature of the neck and how people are sleeping. In this particular instance, this patient was not really sleeping on a pillow. She was kind of sleeping on her arm. So what we found the best results are for our patients that have, and again, we're talking reproducible pain in the neck, which is muscular in nature, are the foam type pillows. And there's a ton out there. The Tempur-Pedic ones tend to be the best, but they are expensive. They're very expensive. Pills, like some of them are $120, $130. But anything that, again, has that memory foam tends to be the best because it will adapt to your curvature.
Excellent. Someone asks, how does a patient in another state consult with a Syringomyelia physician who is an expert in the field? Can it be done remotely? How do we find true experts?
I'll defer to both my colleagues here as well, but I think one of the, if you want to call it a silver lining of COVID, is virtually every physician now is doing telemedicine. So I think the connectivity, not just nationally, but internationally, is unprecedented and easy. If you have internet access, you can connect with a physician anywhere. And I think, per my lecture, I think it's particularly for Syringomyelia, find somebody who, and I think Dr. Dlouhy really referenced this, talk to somebody who has experience with it, and get a couple opinions. Second opinion, even third opinion's not a bad thing. When you start getting to 4 and 5, it becomes an issue. But again, my 2 cents on it is I think it's easier now than ever to get a second opinion. And I would consult with ASAP. ASAP has a list of, many physicians who are experts.
Yeah, I would second that. And I've had people, email me about something that's rare that I've written a paper on or a study on, that they have a question about. There's some insurance issues and so forth that may play a role, but I think things are getting easier and easier with the telehealth.
Excellent. Wonderful.
Out of curiosity, Dr. Heiss, Dr. Dlouhy, do you guys have second opinion programs through your?
We have we see lots of second opinions. It's I wouldn't say it's a program, but we get referred all different patients from all over, but and they just go through our regular channels. And we'll review them here and kind of look at the images and see if they want to see the person here in person and evaluate them in person, because I feel like for the Chiari, a lot of them, obviously, you have to see them in person to get a good exam.
Yeah, so many centers will have even online where you can look, especially some of the larger universities. Different people, we have one where you can go on, you can even upload films. But I agree. It's a preliminary to kind of get a feel for if somebody can address your case.
Yeah, as we review cases, and if it's something that we think we can help them and we're the best place for them, we'll say that. Or a good place, not the best necessarily. But if we can't handle it, if it's going to take a lot of instrumentation and so forth, we try to identify the right person or persons. Obviously, it depends on what region of the country they're in.
Yeah, I think that's smart. That's good, John.
Okay, how evident is arachnoiditis on an MRI? Long narrow syrinx showing up on MRI T6 to conus. Would arachnoiditis have been ruled out?
Generally speaking, narrow syrinxes are not related to arachnoiditis at all, but really you need the whole constellation of neurologic signs and symptoms, and you need somebody to try to put together what's going on. So you can't really say no. It depends. If if you have no neurologic deficit, I think the neurosurgeon would be unlikely to want to do surgery. But if you came in and you were in a wheelchair, then obviously, even though you had a small syrinx, you have a lot of arachnoiditis, a lot of myelopathy. So you need to have a specialist to to weigh in on what's going on.
Is a CSF flow study the same as a cine study? What do they show and what's the difference?
Yes, they're essentially the same. And what it shows is, if you saw that little video that I showed of where that cerebral spinal fluid is flowing freely through the foramen magnum, that's really what we want to see if there's an obstruction of flow of cerebral spinal fluid, and they are the same.
Are there any restrictions with time that would stop post-surgical Chiari patients from going on roller coasters, or in general restrictions that we should not do? I have a cervical syrinx as well.
I'll bet you we're all going to say something different.
Yeah,
Brian?
That's right.
Yeah,
Start.
I'll start. Yeah, so I'm pretty strict in terms of what they can do. I mean, so if they have a cervical syrinx, they have a Chiari. I mean, if they didn't have a syrinx, the same thing. I really don't want them doing anything more than lifting more than 20 pounds for the first kind of 3 months. They kind of graduate maybe to 25, 30 pounds at 4 months. And usually no more than 50 pounds at 6 months. There's no roller coasters. There's no trampoline, no wrestling, no football, no zip line. And basically for those first like 6 months, pretty strict. And then sometimes I can go longer. And I just, for my patients, I try to tell them to avoid contact sports. Most of those for the young kids, and that's true for no matter what, whether they have a Chiari or not. I just think football and wrestling and things like that they can cause a lot of injuries.
John, you're on mute, so before you come off, my philosophy for probably the last decade, I used to be a lot more conservative, but as long as there's no after surgery, generally 3 months once the patch is sealed in and we're not worried about a leak anymore, I tell patients you don't have a Chiari anymore. Chiari decompression takes care of the Chiari. As long as the syrinx is gone, the Chiari is well decompressed at 3 months, I don't give my patient, they have no restrictions.
I'm a little bit older now. It used to be when you're younger, you heal a lot better. When you're older, I think you should take it easy because any of those activities could injure you. You don't need to have Syringomyelia. So, yeah, if you're going to work out, I would work out. I mean, if you have the money, with a personal trainer or with some sort of advice, because when you're young, you won't hurt yourself. When you're older, you potentially can.
Yeah, I mean, once a Chiari patient, just to be clear, untreated Chiari, you do have to be extremely cautious with anything that's going to give a whiplash type injury, playing contact sports. That's a different situation. But if they're decompressed, I'm not really sure what you're preventing. And I think the issue of football and contact sports, which I agree with you, Brian, I think that's a separate issue, Chiari or not. But as far as the re-injuring or re-herniating, I hate to keep people from living their lives.
Okay, if a syrinx shrinks, why would symptoms still get worse?
Yeah, I tried to address that in my talk. That last slide I threw on there, I saw that. That's just, and Dr. Heiss can comment on this too. But that collapse of if it's a large syrinx and there's a collapse of that syrinx, and it's usually holochord syrinx. And that picture that I showed, the syrinx you still see a cavity in the spinal cord. It's a damaged spinal cord. And so you get these dysesthesias. So I really try to tell patients, hey, look, we could do this great surgery. Your syrinx is going to go, completely down, and your cord's going to be deflated, and you're going to get great radiological imaging. But we may have some other problems post-op. But that's better than allowing someone to go forever with a pressurized, dilated spinal cord. So they'll need Neurontin, gabapentin, Lyrica, other pain management. Maybe Dr. Heiss could comment on that. I don't know.
Yeah, I mean, some of the best looking results on MRI can be in patients with a lot of pain. And we don't know if that's due to what's called gliosis, in other words, the healing within the spinal cord, or it might just be that the nerves work better so you can actually feel the pain a little better. But in general, that doesn't last forever. It lasts maybe a few months, and we get people through it with medication, and then generally it's better. I mean, in the long term, most people with syringomyelia associated with Chiari have less pain. However, under stress, a lot of times the pain comes out, like, I mean, anybody would be hurting if if their husband left them, if, they had a major health problem, if they had something else, just about everybody would be down in the dumps and be hurting. If they had an underlying pain problem, that would make it worse. So it all depends on the situation. But so you have to try to lead a healthy life too. That's important.
Well, it's interesting you mentioned stress, because one of the next questions is, can stress make symptoms worse? So,
Stress makes everything worse.
I can agree to that.
Yeah.
Are there neurosurgeons that treat Chiari symptoms as opposed to surgery, or should patients consult a neurologist for issues such as headaches, vertigo, etc.?
Per my discussion earlier, I think if somebody has a Chiari, they're going to be followed by a neurosurgeon. And I feel, my philosophy is that neurosurgeon should be the gatekeeper. Does that mean that he or she's going to be treating the headaches and the associated symptoms? No, but they should kind of be there to help guide it. And whether it's a headache specialist or a primary care physician, somebody needs to be addressing the headaches. But I think the key there is really having a gatekeeper. And it could be a reverse. A neurologist can deal with the symptoms, but the neurosurgeon, but there has to be one point of contact, because I think in most people's experience, that's where the problems occur.
Wonderful. Lowering inflammation, will that reduce the severity of Chiari symptoms? Anybody have any thoughts?
I think that's you, John.
We've
And Allison as well,
You've
Dr.
given
Koch.
us a hard time about this for years, but we did a lot of spinal taps on patients with Chiari and Syringomyelia. None of them ever had any white blood cell counts that were abnormal. So as far as inflammation itself, the classical type associated with infection or arthritis or something like that, no, Chiari and Syringomyelia don't have that. That being said, all these drugs like the NSAIDs, they have some pain relieving qualities, and Tylenol and so forth. So you might not be knocking down inflammation, but you might be feeling better, which really, that's what you want anyways, right? So you don't really need to, in the black box, see inflammation. You just take the medicine. If it makes you feel better, as long as it's not a narcotic, you probably feel better, and the people around you will feel better too.
Knowing that the pituitary can be affected by Chiari, example, empty cilia, can Chiari affect the lymph system in any other way?
I can speak on that.
Any thoughts on
About 10% of people with Chiari, no, about 10% of people with this condition called pseudotumor, which is now called idiopathic intracranial hypertension. Generally heavy people, but not necessarily. They will have Chiari, and those same people can have empty sella syndrome, and other people can just have empty sella syndrome, and it's not associated with anything. But if you're a little bit heavy and you have headaches and you have empty sella, the neurosurgeon has to recognize that, because you're more likely to have leakage of spinal fluid after surgery, and maybe something could be done to treat the underlying condition. Somebody has to just be cognizant of what's going on. And there's actually this one, and we had him at a meeting. He was looking, Kenny Liu actually, who's at Hershey now. He showed that the transverse sinus, which is a big blood vessel in the skull, was narrowed in some patients with Chiari. And so really, the neurosurgeon, he'll check out what your vision's like, and if you have high pressure in your head. And if they recognize that, maybe rather than getting a decompression, you need some other procedure or intervention for something like that.
Yeah, John, it's interesting you mentioned that. There's a lot more research and looking into venous sinus drainage, particularly in the transverse sinus with pseudotumor cerebri. We're actually doing a trial now with angioplasty stenting rather than committing someone to a shunt. And I think that's a huge thing that we just never really thought of before. It's a really good point.
Competitor. I shouldn't have mentioned Kenny. I just know him from the university.
No, he's actually a great guy. He's actually you mean Kevin Koch?
Kenny Liu, didn't he go up?
Oh, Kenny Liu. Yeah, no, he's a colleague, great guy.
So are shunts still used in the treatment of syringomyelia? Can they improve pain and weakness bilaterally? And is there still a large prevalence of shunts failing? Yes to all of that.
Do either of you use shunts? Are there any cases where you will shunt a syrinx?
No. What we do is if it's Chiari related and it's from adhesions and scarring, then we approach the problem, which is the outlet of the fourth ventricle and the scarring around the foramen magnum, and that often has good results. It's different if there's other kind of different types of trauma and primary syringomyelia, but that's the same thing. If there's a trauma from a spinal cord injury, then we treat the same problem. We do a decompression at the level of the injury where the block is in the spinal cord, and take adhesions down there.
Yeah, same. I haven't put a shunt in 20 years for a syrinx.
So speaking of 20 years ago, this person was told that they needed surgery for Chiari 1. Ultimately, they did not go with surgery. They have mild symptoms, but they seem to be getting worse. How does age affect success?
Probably atrophy. I think as age, and again, this is anecdotal, the older we get, there's atrophy of the brain, which is natural. I think it opens up that fluid pathway. Cerebellar atrophy is common as well as we get older. So I think there's a component of that. My guess is for this individual person, you had a Chiari that has been watched, and now it's becoming symptomatic. And it's depends what the imaging looks like. Is the herniation worse? But if the symptoms are worse and there's an underlying Chiari, most likely there's progression there.
Dr. Heiss, who is responsible or who is doing research or clinical trials relating to diffuse arachnitis?
Well, I was going to take it on. It's, who is? Not many people, to tell you the truth. I think, like a lot of things in medicine, the breakthroughs are going to come from related specialties because abnormal fibrosis is a problem. Say if you drink too much and you have cirrhosis of the liver, or you have cirrhosis just because you have hyperfibrosis. I mean, there are people who have a lot of abdominal pain from a lot of fibrosis, or people who have abundant, overexuberant wounds, like keloid formers. So too much fibrosis is common in a lot of conditions. And people like Allison she'll put it together because basically it will be those genes in the different organs that are revving up fibroblasts and other cells that are leading to fibrosis. And somebody will come up with a good drug to prevent liver cirrhosis, and they'll probably apply that to arachnoiditis of the spine, So there's hope, and it's just not, a lot of these PhDs are doing good work. It's just it's going to take 10 or 15 years for their advances to make it to the clinic.
Why is cow Dura still used for patches? Can't donate blood or anything else now because they're afraid might have mad cow disease. Is that a valid?
It shouldn't be. I mean, there
concern?
used to be. Years ago there was concerns initially with some synthetic bovine substitute for Dura, but not anymore. And it's still being used because in some cases that's just the primary way to it's an easier way instead of taking someone's autologous tissue from the incision. It's an easier way to create a dural patch.
Yeah,
I have a bovine patch myself and moo occasionally, but it's only on occasion. So is borderline Chiari anything to worry about?
I think it depends if you're symptomatic. I mean, so, Chiari 0, borderline Chiari, again, it gets back to, are you symptomatic or not? And are your symptoms related to Chiari? I think is that simple. If someone tells you you have Chiari and you don't have symptoms, they just told you have Chiari and it's something you feel fine, and someone just says you have Chiari, stay away from surgeons.
I should say,
that's my advice.
Yeah, Brian sees a lot of these more than I do, but there are some people who have fusion of the first cervical vertebra to the base of the skull, and they don't need as much protrusion of the tonsils to really be symptomatic. I don't know if you agree with that, Brian, but you can have about 3 millimeters of ectopia in those patients, and they can be as symptomatic as the person without that, with much more tonsillar ectopia. So I'll let Brian speak.
I think both true. Every individual is a little different, and their anatomy is different. It's probably based on the genetics, as was described by Allison in the last talk, so everyone's got to be treated individually, because we know that in some kids, right, they have a more full brain, smaller skull, and maybe they don't need as much tonsil herniation either. And then the foramen magnum size probably plays a role in some cases in these patients that have bony abnormalities. There's less of a space at the foramen magnum because of these bony abnormalities, as Dr. Heiss mentioned. So individual, treatment strategies probably.
And another interesting thing is Jeff Greenfield from Cornell. Everybody looks at how far the tonsils go down, but they go around. It's sort of like fat around the belly. But the tonsils could go around and they can affect like some of the lower cranial nerves. And so he pointed that out to me, and I've seen that more often. So it's not necessarily the number that the tonsils are down. If for whatever reason they're being blocked from going down and they work their way around the medulla or the cranial cervical junction, that can cause symptoms too.
Yeah.
So Allison, we actually have two directed to you. One is, would you be willing to share paper copies of your presentation so patients may use them for education? And then also, do you feel that your genetic studies will not only help those with Chiari 1, but also help identify the elusive genes involved in the hypermobile type of Ehlers-Danlos?
So in answer to the first question, yes, of course. As those of you who watched my presentation know, there were some technical difficulties. So the ASAP group already has my slides. So they are welcome to share those with folks. The other question really is an interesting question because I must say we were surprised too when we found these different genes associated with Chiari, and they have already been implicated in some of these other conditions like Ehlers-Danlos syndrome. So when we talk in genetics, we talk about clinical heterogeneity. And so that's kind of how the patients present their symptoms. And clinical heterogeneity is often tied to genetic heterogeneity. So genetic heterogeneity can both across genes and also within a gene. So for this particular question, it's going to be really interesting just to look very carefully within some of these genes to see which variants are associated just with hypermobility versus those associated with Chiari versus those that may be a combination of the two. But we don't know the answer to that yet. But it's a really interesting question.
I never cease to be amazed by some of the questions and some of the answers we get through these Q&A sessions, and it's just amazing. I absolutely enjoy this. How are Tarlof cysts related to these conditions? Anyone?
I'll have a shout out for Dr. Batzdorf. Dr. Batzdorf told me that we need to have a protocol or some treatment for the people that have Tarlof cysts, or maybe Ehlers-Danlos that have increased flexibility of their Dura, and basically they get a Chiari type secondary syndrome because when they stand up, the Dura expands or the Tarlof cyst fills with a little bit more CSF, and you get a Chiari type syndrome. I mean, I hopefully I'm not, that's how you described it to me. So some patients with Tarlof cysts need to have surgery to restrict the amount of CSF that's going into them so they don't have what's called hypotension, intracranial hypotension when they stand up. I don't do that surgery. Other people can talk to you about that. I think Dr. Henderson does some of that. I don't do it, but maybe you guys do. I don't know.
I don't.
No, I don't either.
I don't either.
But some people do.
Mm-hmm.
And Dr. Batzdorf is interested in it. So if you have a question about that, ask him.
Yeah, he'll be on tomorrow afternoon. So we can add that. Whoever asked that question, ask it again tomorrow. Can you describe how the Chiari syrinx-related hand tremor presents differently from a benign essential tremor?
I mean, they're different. A benign essential tremor has a very specific diagnosis, particular if there's a new onset of tremor with patients with Chiari and the symptoms kind of correlate. That's usually one of the best ways to differentiate. Sometimes it's very difficult. The help of a movement disorder specialist or neurologist is extremely helpful. I showed Jill Farmer, who's on our team, and I defer almost everything with that. But there are lots of different variations of tremors with Chiari, including the truncal ataxia or titubation, hands, arms, head, you can see, as well as the nystagmus or the eye movement, which is also a form of a tremor. And these are all coming from, it can either become interruption of the motor fibers. I think it's more prevalent in patients with syrinx. So there's a lot of different etiologies for it, but essential familial tremor or essential tremor is a very different etiology than a Chiari, which is more of a nerve damage.
Is anyone aware of a genetic test that can be done through one of the online, say like Ancestry or 23andMe, that would be able to identify markers for Chiari?
So unfortunately right now, that's not the way you would do it. You would have to actually go through your physician to get a formal genetic test done. And really at this point, I don't believe, even though we have hints of variants here and there with all these different genes, I don't know that they have really been implemented yet for genetic testing. So a lot of those online services, and I in fact did it myself, you know, are fun because they tell you a lot about just the history of your genome and which different parts of the world your genome came from, you know, and they may sort of track certain different just traits. But for the most part, by far and large, those companies are not allowed to do true genetic testing. So it's more kind of informational, fun stuff rather than diagnostic.
Is it common?
If they think that it runs in the family, they should talk to a genetic counselor, don't you think?
Yes, absolutely. That would be the next step, talking with your physician, a genetic counselor.
Good advice. Good advice. Is it common for bulging disc in the spine and other issues for a diagnosis of Syringomyelia hydromyelia? What happens when doctors have no idea you have these conditions? And I have another one that kind of is along that same lines as possible treatment plans for Syringomyelia hydromyelia with 4 syrinx in the spinal cord. How does one live with this type of diagnosis? Would it involve constant pain? When is surgery necessary?
I think those are related questions, and there's different causes for syrinx. And I think as in several of the talks alluded to, it's very important to find out what the cause is. If there's obstruction of cerebral spinal fluid, if there's a herniation, even if it's mild above and there's a syrinx, that most often is the cause, and it's usually up in the cervix, cervical region. Trauma, bulging discs can cause syrinx. If you have a very large cervical disc or thoracic disc, it does the exact same thing. It obstructs that flow of CSF, and it's almost like a Chiari within the spinal cord. And the treatment for that would be the disc. However, a bulging disc that's not really effacing the cord and there's not an obstruction of flow would be unlikely unless it was trauma. And these are used interchangeably. Syringomyelia, a lot of times those terms are used interchangeably, and it's, you know, we refer to that as syrinx.
So we are actually a little bit over for today. So I'm going to ask one more question. If the CSF flow is completely blocked at the back of the brain, is surgery always recommended? And then is this accompanied with head and neck pain, ears ringing, weakened hand functions?
Well, I mean, if the CSF flow is blocked, and we think that's from a Chiari malformation, so I mean that's one thing we have to confirm that that's a Chiari malformation, and that's blocking the flow. And it sounds like it. I mean, those symptoms sound like Chiari type symptoms: the Valsalva-induced headaches and pain in the back of the head, numbness, tingling, so forth that could be associated with it. But imaging will be required to know whether that's from Chiari or something else. And then obviously the imaging and the symptoms and an exam are going to dictate the proper treatment strategy for that patient.
Excellent. So thank you, doctors, for your participation this afternoon. Thank you for answering these questions. We have a lot more questions that we're going to pull off and circulate. So hopefully we can get the remaining questions on there. So thank you, everybody. Have a great night.